Hi everyone, and welcome to the webinar Fight Against COVID-19 with Ultrasound. Sorry for this delay, and we are trying to fight COVID-19 in all the fronts and linking 3 continents at the same time. North America, South America, and Europe, quite an effort. And my name is José Mariz. I'm an internist in the emergency department of Hospital de Braga, managing multidisciplinary teams across all the spectrum of the emergency care over the COVID-19 units, but also with the admission of all the suspects or confirmed COVID-19 patients, but also in all the spectrum of the emergency care, because we have to treat all the patients and in an environment with safety. And first of all, I want to thank all those who signed up for this webinar and to be patient to wait this small delay. And as far as now, I think we have almost 1,000 of attendants. That is quite a big achievement and a quite big responsibility. I have to deeply thanks to my wife, Joana Constantino, who has been coordinating all the event, besides running up a family confinement with 2 daughters and an emergency physician. And of course, to all the staff of the Portuguese Society of Internal Medicine, especially to Engenheiro Nuno and Isa. And I want to deeply thank Stage 10, who from Canada, who gently gave all the necessary technical support to put this webinar on. That is not an easy task, okay? I'm currently the coordinator of the Ultrasound study group of the Portuguese Society of Internal Medicine, and it is in this role that I am the host of this webinar, Fighting COVID-19 with Ultrasound. I'm very honored to join so brave and committed doctors working in the front line of these pandemics, and who use every day point of care ultrasound. This webinar is not a point of care ultrasound course. Our main objective is to highlight and to frame in the context of the COVID-19 pandemics what are the main aspects to be aware of prior to apply an ultrasound program for COVID-19 in your hospital. We will try to answer all the questions you may post in our chat, but at the end we will gather all the questions and answer them in a PDF to share with everyone. And let's introduce our dear guests. And Michael Blivas doesn't need any formal presentation. Along being a great friend and mentor, he's a worldwide known pioneer in point-of-care ultrasound. Currently, he is an emergency physician from St. Francis Hospital Emergency Department in Columbus, Georgia, United States. And he will talk about what are the patterns seen in COVID-19 pneumonia on ultrasound and putting together your long artifact findings, okay? Costantino Caroselli is an emergency and urgency medicine and geriatric doctor from the Geriatric Emergency Room and Aging Research Center in Ancona, Italy. He is the director of several courses of point-of-care ultrasound across Italy, with several peer-reviewed publications on ultrasound. He will talk about the role of lung ultrasound in triage and monitoring patients. And Yale Teng Chang is an emergency medicine physician who recovered recently from a COVID-19 pneumonia. This is quite an awesome topic to put in your curriculum. He currently serves as the director of the ultrasound division at Hospital Universitario La Paz in Madrid, Spain. He will talk why take to time and use ultrasound in COVID-19 in the emergency department, and how to do it with handheld machines, the cart-based machines, with practical tips on protocols and safety. And Tiago Santos, one of my greatest friends, and actually everything I know on ultrasound, I've learned with Tiago Santos. He is associate professor of emergency medicine and medical coordinator of the emergency intensive care unit of the General Hospital of University of Campinas, the well-known Unicamp in South America, Brazil. He will talk about the challenge of doing point of care ultrasound in an intensive care unit in the context of a pandemics, and with a focus with cardiac ultrasound and lung and heart interactions. And let's go to begin. To begin, I will show 3 clinical cases to present the roles of lung ultrasound in the emergency department might be, based on my own experience in a COVID-19 unit in the emergency department of my hospital. I work in a COVID-19 unit within the emergency department. We admit all suspected or confirmed cases of COVID-19 that enter by the open door of the emergency department in our national health system, or transferred from other hospital, as we are the reference hospital for several specialties as cardiology, nephrology, and neurosurgery, for example. Here we also collect nasal and oropharyngeal swabs for RT-PCR for COVID-19, and stratify patients to a regular ward if COVID-19 negative, or to a general COVID-19 ward, or a intermediate care unit COVID-19, or to the intensive care unit. Here, the security of staff is paramount, and the use of ultrasound reduces the need for radiology and shortens the patient's stay with better screening. Some creativity was needed to simplify the ultrasound system, and finding a system with smooth surfaces, easy to clean, with easy and cheap lids to cover the ultrasound machine and to replace. The use of cover probes is used as much as we are not on a shortage of them, but other solutions to ensure that the gel is not contaminated should always be accessed. Then, let's begin with case 1. Case 1 is a female, 45 years old, with a patient medical history with a lymphoepithelioma 5 years ago, cured. And she was a patient already with a COVID-19 positive by swab of nasopharyngeal, diagnosed 7 days ago, and she was oriented from the medical officer of health to stay at home, recovering, and without any epidemiological link. She presented to the emergency department with complaints of pleuritic pain with deep breath and anosmia in the last 24 hours, and without reported fever or cough, and without other complaints. The clinical examination, she presented with good general condition, vital signs normal, with a normal auscultation of lung and heart, and abdominal normal and without peripheral edema. The exams like the EKG normal, blood gases with any pathology, and phlebotomy with D-dimers in the range of normal, total leukocytes and lymphocytes in the normal range, with a slight elevation of the C-reactive protein. Then we did the lung POCUS, at point of care ultrasound, and here, to achieve sensitivity, through lung examination will be needed. We have to take a lawn mower approach, attempting to visualize as much lung tissue as possible. A simple two-point lung ultrasonography examination will miss focal ground glass opacities. This is very important during lung POCUS, especially in the COVID pandemics. If you see, like, to visualize the A pattern in the apex, then going through the middle fields of the lung with an A pattern also, then reaching the posterior parts in the middle fields, and you see that clearly an A pattern, and you have to be like the lawnmower, like sliding with the probe, and as smooth and quick as possible, and then going to the bases and like checking the PLAPS point. Here is very important to have the knowledge in the tip of the probe to be sure that you are seeing an A pattern or a dry lung, which has a high negative predictive value for an inflammatory lung. So from the apex, going to the middle fields of the lung, always looking very carefully to the posterior parts of the lung. The bases should be fully examined in the PLAPS point, looking for effusions, and going again to the back as patients without respiratory symptoms in the context of the COVID-19 pandemics could have ultrasound findings. And we'll see along the presentations, the most common findings in lung ultrasound are in the posterior parts of the lungs, and even in the superior aspects of the lung, and seeing the A pattern, clearly the A pattern. Okay, pleural line, A lines, okay, dry lung. So the patient was discharged at home with a short stay in the emergency department and without doing a radiological exam. Okay, then case 2, male, 76 years old, with diabetes mellitus type 2 well controlled and dyslipidemia, and he presented to the emergency department with a very good shape, with a dry cough for 9 days, fever in the last 4 days, and myalgias, without shortness of breath, and with a suspicion of an epidemiological link. Actually, he was a very active man. He was still running his company of constructions, and he had a contact with French workers 2 weeks ago, but without reporting any contact with people with respiratory symptoms or COVID-19 positive. He was really in a very good shape, actually. His granddaughter was anesthesiologist in our hospital, and it was she that came with his sir, and at clinical examination he had normal vital signs, slightly hypertensive, without fever, the saturation of oxygen 97%, eupneic without any respiratory effort, the cardiac and heart auscultation and pulmonary auscultation with any abnormal breath sounds, without pathology, and normal abdominal exam and without peripheral edema. And then the blood gases, quite okay for his age, and the phlebotomy with a creatinine 1.4, but he has like registration of a basal of 1.6, and the C-reactive protein moderately elevated, 112 milligrams per liter, with a slight lymphopenia and a slight thrombocytopenia. Then we checked quick the lung ultrasound, and if we see, this is striking, at the apex, at right, we start to find multiple findings which could be characteristic of COVID-19. The pleural line here is unsmooth. Sorry. And smooth. And then an important sign is that you see like clearly fused B lines, the waterfall sign. And what is important to note is that there are spared areas with an A pattern. And this is very important. You are seeing here the B lines, the fused B lines, and an A pattern spared very clearly in the apex. Then in the left apex, the same thing. You see here like irregularities in the pleural line. Here a normal pleural line with an A pattern, and then clearly here some subpleural consolidations, and then some irregularities in the pleural line, and here the waterfall sign, the B lines fused. Okay, and going further in our lawnmower approach through the middle fields, always looking in the posterior areas of the lung, and then here in the most anterior parts of the lung. Okay, and you see some spared areas with an A pattern, some B lines, a fixed B line, and here some irregularities with a more pronounced B line here at left. And you see here that the pleura is not linear, okay, with some irregularities. And then going to the posterior aspects of the lung, you see here some A pattern with a one or two B lines, and here you see more fused B lines and with a strong signal from pleura, and that is unsmooth. Okay, the subpleural lesions are more difficult to identify, but they can show patchy or on strip or with nodal consolidations, and you have to be like very careful and to see that here some aspects of the pleura. Then at the bases, always looking very important at general inspection of the lung, looking at the bases, the Plapp's point, differentiated what's in intra-abdominal and intrathoracic. You see here at the base, it's paired with an A pattern without B lines. Here a smooth sliding of pleuras, and it looks like the base at right is spared, and then in the left we see some irregularities here. Okay, and then going to the posterior aspects, the most important findings are in the posterior aspects, and you see here the fused B lines, the waterfall sign, here irregularities, the pleura that is unsmooth, and actually you could see here some subpleural hypoecogenitis, and it could represent patchy consolidations, and the B lines start over there. And you know that in other aspects of the B lines, like in cardiogenic edema, the pleurals is smooth, and here you see the irregularities that are quite different. Okay. Then in the posterior parts, in the superior parts, okay, and again the B lines. What is more striking in this patient is that he was in a very good condition, not showing any sign of respiratory distress or shortness of breath. And actually we did a portable chest x-ray, and that showed ill-defined opacities in the left zone. But you know that these infiltrates may be subtle on chest X-ray and very poor specific, and add to this the need to transport the portable X-ray to the unit. And in our hospital, in our protocol, could only be done in batches of 2 or 3 periods in 24 hours. That makes that we have a lot of patients that could enter at 8 a.m. or 9 a.m. and they wait to do the chest X-ray till 5 p.m. And with this ultrasound, we had a high suspicion of being a COVID-19 positive patient before doing the test, and which lasts at least 8 to 12 hours in our institution. And we have a very rapid response. And some points in Portugal, you could wait for 4 or 5 days for the result. And we admitted him in the COVID-19 a regular ward, and afterwards he had a positive result, and already admitted to the ward, and with a fast stratification, and lasting the shortest time in the emergency department. Then let's go to the case 3. It shows a male 40 years old without any past medical history. He presented to the emergency department with complaints of a dry cough and myalgia since 10 days from presentation. He had fever, 39 degrees of Celsius. He did 3 days, in the past 3 days, with amoxicillin and clavulanate given by his doctor by phone call without improving. And he was like with dyspnea in the last 24 hours without any epidemiological link for COVID-19. And he was like sick, sudoritic, polypneic, slightly hypertensive, with a saturation of O2 that 90% in ambient air. 2 hours after taking 1 gram of paracetamol, he was 36.4 degrees of Celsius. And we heard crackles at bases with a normal cardiac auscultation without peripheral edema. The blood gas is showing a slight respiratory alkalosis with a PO2 of 68 for a patient of 40 years old, worrying us. And the phlebotomy showing a moderate elevation of the C-reactive protein, and a slight elevation of the dimers of 1028 nanograms per milliliter. And then the lung POCUS, as you previously have seen, there are multiple findings which could be characteristic. I will repeat some of them. The pleural line is unsmooth, and here at left you could see more clearly. Here, okay. Here, with discontinuous and interrupted, and also the fused B lines. Then at the middle fields, you have like the spare parts of in the anterior parts of the lung with some A patterns, and then some fixed B lines. In some aspects we could replicate the findings that we saw in the other patient, okay? But now you'll see that the other patient was like feeling in good shape without symptoms, and this one was sick. And here you could see like the irregularities and the discontinuous and interrupted pleura. And if you take note, some like, if you see with detail, some subpleural hypoechogenitis that could represent consolidations that are characteristic in COVID-19 infection. And then always the posterior parts, and you see the waterfall sign, and you see the irregularities, the pleural unsmooth pleura, and here some consolidations, and here clearly the fused B lines that are more pronounced in the posterior aspects in the of the lung here, like a patchy consolidation, okay, or nodular patchy. And then here with more detail, seeing the unsmooth irregularities of the pleura, and then spared with some A pattern, and then you can see here some consolidations. And going farther at the bases, here we have like the bases with a more pronounced involvement, and you see an smooth pleura with fused B lines without pleural effusion, which is very rare or uncommon in a COVID-19 pneumonia. And here the irregularities at the right, and the posterior part of the lung at right here with a lot of the irregularities and nodular consolidations, patchy ones, okay, and the waterfall sign, fused B lines, okay, here can you see with more detail. And then at the left also an unsmooth pleura on a 40-year-old man without any past medical history, and this is striking. Here you see that the more intense B lines like start at the subpleural region in hypoechogenic nodular consolidations, okay, here. And then this patient was stratified like as a sick patient with moderate disease, and we suspected very early of COVID-19 infection, and we signaled the patient to the intermediate care unit, and then where he was transferred after having the positive result, and we did the CT scan with all the protocol for COVID-19 that confirmed the ground glass opacities in the superior median lobes and lingula, and peripheral consolidations in the inferior lobes, and these aspects were shown with a very reasonable concordance with the lung ultrasound, and the need for the CT scan at the beginning of the evaluation didn't exclude the ultrasound at the point of care. And then the monitorization of the patient during treatment and hopefully during recovery in the unit could be used as needed. And as you see, this case shows the good concordance between the lung ultrasound and the CT scan. The patient has a test positive for the COVID-19, and he was admitted to an intermediate care COVID unit. Then, in summary, the temptation to get a CT scan in all these patients should be resisted. In most cases, mainly in the emergency department, or when you have a big series of patients, a CT scan will probably add little to chest X-ray and lung ultrasonography, but please understand that this view is in terms of actionable data which affects patient management. Consider the CT scan only if this will affect the management, as ultrasound cannot replace a CT scan. But these three cases highlight the role of ultrasound on triage and stratification. Like in the case one, a patient that potentially is in the time of the beginning of the critical period, but in a good shape with a good saturation of O2 and with a normal lung ultrasound, the NA pattern, and safely we can discharge home. Or the case two, the contrast between a patient that looks very good, but you demonstrate lesions that could perceive the symptoms in the COVID-19, and this patient is more reasonable and admitting his age of 76 to admit to the ward and to see the evaluation in the first 2-3 days. And the case three, a patient that looking, and then the case two also, that we expected the diagnosis of COVID-19 with the ultrasound, and we didn't wait, and we admitted the patient. And in some places that could be very important, like, because it could last like 3 or 4 days to have the result. And the case three, a patient that looked sick and was in a critical period, and the ultrasound was very important for the stratification, and even to compare with the CT scan, and even for the doctors that are doing the ultrasound, always checking their findings of ultrasound with CT scan, and to better address and those changes. And he was admitted to an intermediate care COVID unit. Then take-home message: lung ultrasound has some advantages in the context of a COVID-19 outbreak. May be performed at the point of care, including outside the hospital. This avoids transporting the patient to radiology with possible exposure to the hospital staff. Could be helpful as an early detection tool in patients who are under suspicion of having COVID-19, as these cases have shown. And ultimately, the imaging is only one bit of information that must be always integrated into clinical context, but it's just a big bit of important information. COVID-19 has completely changed the landscape of healthcare, but we will win this fight together. Thanks. You may email me to the email that is shown in the slide, and thank you very much. We'll go next with Michael Blivus.
Hi, everyone. Thank you for taking the time, wherever you are, out of your schedules to join all of us. I am very privileged to be here as a member of this panel to present to you. I'm an emergency physician in the United States. I work in a very high acuity community hospital in the South, and we are starting to see a tremendous number of COVID-19 patients, all of which are getting ultrasounds from me. I'm going to do a brief presentation on some of the nuances of lung ultrasound, since that is clearly one of the most important ways that we can help our patients at all, but especially with ultrasound. I do have one disclosure. I'm the Chief Medical Officer for an AI and handheld ultrasound company called Equinos. I will not be discussing their products specifically by name. I have several objectives today. I'm going to try to discuss some of the nuances of lung ultrasound, especially how they relate to COVID-19 patients. I'm going to also discuss how to differentiate COVID-19 findings from other chronic lung and non-chronic lung processes, which is something that I see in my population a lot, because almost everybody has COPD and congestive heart failure as a baseline. So we've seen some evidence emerge about lung ultrasound and COVID-19. A journal that I am editor of has published on it as well, and that is the Journal of Ultrasound in Medicine. And so the data is coming out. But here's a nice study out of China. They looked at approximately 20 COVID-19 patients, and interestingly, they compared their ultrasounds to chest CT, which is where the majority of the data sits right now. They had some interesting findings. One of the hallmarks is thickening or irregularity of the pleural line, B lines in various patterns, various consolidations. Pleural effusions, however, were quite rare in these 20 patients. Obviously, it's a very small sample. We already know from work like by publications like Dr. James Tsung from New York, I believe at Mount Sinai, that we don't want to miss the posterior aspect of the lungs, even though traditionally that is something that has been left out in many lung applications that have been described. Because if you do, you can miss important findings. We know that from the Chinese publication, one of the fastest ones to make it, we're looking for thickening of the pleural line, various B-line patterns, and consolidations. And this is an example. This is from a COVID-19 positive patient, and what you see is completely normal pleura, and then all of a sudden this kind of disruption, this subpleural consolidation, and it's generating B lines. But that is a source of considerable confusion for many people, whether that's truly a B line or in actuality more of a reverberation artifact that's not the same as a B line. Anecdotal reports support this as well, where you have pleural line disruptions. This is a patient with COVID-19 that I scanned, and much like the literature so far suggests, some of the pleura is normal, and then things like this come up, and this is a patient that I would have not suspected of having COVID-19, and we even see this kind of subpleural consolidation in certain areas. Now, B lines, the term does cause a lot of confusion. They should be well defined, quite stable, like in this case, going down at least 10 centimeters or further, and emanating from a fairly normal looking thin pleural line. So these are B lines in a congestive heart failure patient, but this image is actually probably not of B lines. In fact, we know for sure this patient did not have congestive heart failure. This patient had chronic lung disease with scarring, and these are all reverberation artifacts emanating from a pleural line which is very irregular. Notice how disrupted and thickened it is. In fact, we can see it a little bit better here, this particular subpleural consolidation, and it almost looks like we're having some of the B lines emanating from those consolidations, like right here. So do we really call these B lines? The thought is probably not. Maybe comet tail artifacts, that has been suggested. And the real importance for this is because you can have B lines that come from wet lung, and then what could be called B lines, but maybe shouldn't be, that comes from abnormal pleura that's inflamed, infected, or somehow diseased or scarred. And this is something that will help us differentiate patients that are COVID-19 positive from others, especially if we don't have more pronounced findings like in this case, but have fairly subtle ones. And it's also very important to use a transducer that allows you to cut the depth significantly so you can examine that pleural line. Is it nice and thin and kind of straight across, or is it irregular, uneven, and thickened and disrupted like in this COVID-19 positive patient? And obviously we want to pick up the small subpleural consolidations like in this case. Notice that pleural line, it's beautiful. And then we find this in a COVID-19 positive patient, and that's one of the episodic lesions that help us diagnose patients even if they have few other symptoms in many cases. As we've heard, distribution, the pattern, where you can find the lesions is very important, but I think the pleural line is still key to differentiate patients with COVID and those without, especially in patients that have a baseline COPD or baseline congestive heart failure who may have B-lines right next to lesions that are consistent with COVID-19, and I'm starting to see a lot of patients like that. Thank you so much for listening, and I'm very much looking forward to the other presentations.
Good evening. My name is Costantino Caroselli, and I am an emergency physician from Italy. I work in a hospital named IRCA in Ancona. And first of all, I want to thank Jose and the other friends for the invitation to speak about the role of lung ultrasound and triage and monitorization of COVID-19 patients. At the end of January in Italy, we had the first case of a COVID-19 patient. There was a couple of Chinese tourists coming from Wuhan. So we did the questions ourselves, just two occasionally infected in Italy. But at the end of February, a 38-year-old Italian man was admitted at the hospital for a severe case of atypical pneumonia, and he resulted COVID-19 positive. So he didn't travel to China, and our question was again, just one occasionally infected in Italy, too late. Because in the middle of March, Italy has had, unfortunately, more than 15,000 official cases, over 1,000 recovered patients for COVID-19, and over 1,000 deaths. So, COVID-19 pandemic. We know that triage plays a pivotal role in emergency urgency, but in a pandemic it plays a decisive role. Triage in pandemic has many things to remember. The acute pressures of a pandemic infectious disease result in much tighter boundaries for admission decisions, because they likely rape the exertion of a critical care capacity, and moreover the need for a better risk stratification due to limited resources. And furthermore, the need to improve resources utilization. We know that infection by COVID-19 has three forms: a mild form with no symptoms, or cough, fever, diarrhea; a severe form with dyspnea, hypoxia, more than 50 lung involvement and imaging; and a critical form with respiratory failure. We know that traditional approach in suspected COVID-19 patients as objective examination with the use of stethoscope, chest X-rays, and chest CT. But using all these things, we have the possibility of contamination of the medical devices and spread infection, so we can have more doctors, nurses contaminated, radiology technicians, hospital porters, and many more patients. So our question today is there a role for lung ultrasound POCUS in the triage? I found this interesting paper that was published a few days ago, where we ask if is better less stethoscope or more ultrasound use in COVID-19 patients. And Dr. Volpicelli say that lung POCUS ultrasound, lung ultrasound POCUS at the triage may be the main character. We know we have a patient at the triage with signs and symptoms with a fever, cough, respiratory failure, impaired ventilation, asthenia, myalgia, anorexia, diarrhea, vomiting, one or more of these symptoms, and so absolutely isolation of the patient. He proposed this kind of algorithm of choice. Clinical examination and lung POCUS bedside and nasopharyngeal swab for COVID-19 testing, PCR, and two possibilities. One possibility is with the POCUS negative, so if the patient is in a good condition, he can go home and stay in a quarantine. Or another possibility at the triage with the POCUS lung ultrasound, pneumonia, so chest X-rays and or CT and blood tests, and then we decide what we have to do. So lung ultrasound can help us to do this kind of choice. This is another interesting paper published a few days ago, where the authors ask themselves if there is a role of lung ultrasound in COVID pandemic. I think that lung ultrasound POCUS in the triage may represent an important instrument for monitoring the patient bedside, because it reduces time consumption, optimizes the therapeutic strategies, especially in critical patients and in ICU. And it provides further clinical information, limiting unnecessary additional imaging resources. And furthermore, it reduces the risk of further infection by transporting patient to radiology, so reduce the risk of infection for the operators and for the devices. Because the device can become a vehicle for infection. Moreover, lung POCUS, together with the clinical and the laboratory data, may be helpful to determine whether need to ventilate or whether need for intubation and thus severity. Lung POCUS findings at the triage, we know that show us different scenarios, different form of symptoms or signs, because we can find a thickening of the pleural line with a pleural line irregularity. We can find the B lines in a variety of patterns, including focal, multifocal, and confluent. Or we can find a consolidation in a variety of patterns, including multifocal small, non-translobar, and translobar, with occasional mobile air bronchograms. So, in the monitoring of the patient, if the conditions are better, we can see the appearance of A lines during the recovery phase. And another important thing is that pleural effusions are uncommon in these patients, except the patients that have this effusion for other problems, or if they have before the COVID infection. We have some imaging here. There is a pleura. We can see the thickening of the pleural line with the pleural line irregularity, and this is a sign we can find in lung ultrasound POCUS. Another kind of sign is the presence of focal B lines. We can see focal B lines that begins from the pleural line. Another imaging that we can find in these patients is the presence of multifocal B lines. Also in this situation, the B lines begins, of course, from the pleural line. There is another one where the B lines are confluent, so we can have an imaging of white lung. And finally, we can find sometimes a small subpleural consolidation under the pleural line. I found this interesting algorithm from Dr. Stone that can be applied in triage in COVID-19 patients. We don't have we have to remember that this algorithm need to be validated from trials and more studies, multicentric studies. But I think that is interesting because we have the patient at the admission in hospital with fever, cough, fatigue, dyspnea, or other symptoms that we said before, or known COVID-19 contact. So the initial diagnostics, rapid flu RSV, COVID-19 PCR, pulse oximetry, and lung ultrasound POCUS. We can have 4 kinds of findings beginning on our left. We can have a patient with that doesn't require oxygen. And at the lung ultrasound POCUS, it shows A lines. So the recommendation this patient is stay at home in quarantine. Then we have another finding where the patient also here doesn't require oxygen supplementation. But at the lung ultrasound POCUS, we will find B lines. So here is the recommendation is stay at home in quarantine, but with a follow-up, of course. So the patient have to communicate with the doctor if his conditions worst. And then there is a third kind of findings where the patient require supplemental oxygens, and the lung ultrasound POCUS shows B lines. So in this case, the recommendations are viral testing, daily lung ultrasound, consider dedicated lung ultrasound POCUS. And at the end, on your right, we find a patient where there is required oxygen, supplemental oxygen, and we find consolidations present. So here the recommendations are viral testing, daily lung ultrasound, potential echo, and sure recommended dedicated lung ultrasound POCUS. So, just few messages more. Lung POCUS may help to decide if patients can be sent home under quarantine, to decide if patients need to be admitted to the hospital and thus severity, and to reduce the risk to contaminate other people. Development of a prognostic index in recovered patients, and furthermore, a possibility for monitoring. This is just a hope. This is the situation in Italy, the up-to-date of yesterday to yesterday. We can see that the situation is not worsening, but our hope is that we have no more positive patients, and that we have, of course, much more patients healed. and that the deaths are near zero. I thank you for your attention, and I want to thanks to say thank you to my colleagues, to the nurses, and all the others that I work with the hand, and be safe.
Good morning, my name is Yale Tong Chen. I'm an emergency physician working in Hospital Universitario La Paz in Madrid, Spain, and it is my pleasure to talk about safety and protocol of an ultrasound scan for COVID-19 infected patients. So let me first introduce you to my hospital. It is a tertiary and academic hospital in Madrid. We have around 2,000 beds, and this is the emergency department. When we first started with the COVID crisis, we only had 2 isolation rooms. That after that, we had to adapt our emergency department to the increasing number of sick patients who came to our emergency department. So we moved from a couple of patients at the beginning of March to more than 300 at the peak of the epidemic. Right now we have around 100, but we had to prepare a tent outside the department, also to habilitate the gym, the family waiting room, and so on, in order to treat all our patients. And our protocol in our hospital, the main pillars to manage COVID-19 patients rely on the X-ray, chest X-ray, with the oxygen saturation, and even the physical exam, auscultation. So in cases where available or indicated, also on the PCR. So why people like us who love ultrasound, we don't put into that protocol the ultrasound if we know is it useful? As point of care ultrasound is readily available, it's has no radiation, portable, and worth cost effective. Let me go through the main reasons why we should apply point of care ultrasound to our patients. First of all, how good is our physical exam? Do you auscultate your patients? So this is the auscultation from one patient with COVID-19 on the right lung, and now on the left lung. So as you can imagine, unless there's a pneumonia going on or a very advanced disease, the auscultation probably doesn't give you that much information you would expect. Then we move from hearing to seeing with ultrasound, and here we have a consolidation with a thickened pleural line and confluent B lines in that image. Even an hepatinization, which we saw in a bacterial infected patient, and even slight pleural effusion, more sensitive than CT scan to detect the effusion. The other pillar for managing these patients are the chest X-ray. This is the chest X-ray from a patient who was normal, but then you see here the lung ultrasound with the thickened pleural, B-lines, and even subpleural consolidations. This patient didn't have COVID, had measles pneumonia, but this is one of the main limitations for lung ultrasound, is that it gives you the similar pattern in any viral illnesses. So right now the main viral illnesses we are facing anywhere is COVID. So that's why we should suspect it by finding and by looking at these findings. So what is the protocol we use in the emergency department? First, we need to differentiate two types of devices, the card-based and the handheld devices. My advice is definitely anytime you can use the handheld. It's much easier to take, to clean, to decontaminate, and to repeat it. The card base is just really hard to do the number of exams you would like to do, and every time you clean it, it takes much time to do it. And also you face other problems that are the many cables, cords, probes that you need to take off, the basins, guard, and any extra things you have there that you need to take it off. So if you have a card base, you still can use it, but try, if possible, if you have more than one machine, to leave one only for COVID-19 patients. So before starting the exam, before entering the room, try to set up all units, so by going inside you don't have to touch anything in the screen. You adjust the gain, the depth, so you can perform the exam as rapidly as possible. Take an extra pair of gloves, as the ultrasound device should be an extent of your personal protective equipment. So anytime you remove your personal equipment, you should have a pair of gloves extra to do the same procedure with your ultrasound device. This is the cover I use for my handheld device. I put it in the there with my cell phone inside, and you don't need to be sterile, as you can see in my picture. I take the cover and put it around the probe, and then put my cell phone inside the cover. And then what I do is to perform one exam and clean it afterwards with Vircon. As we are running out of many resources, materials, so are the covers. I cannot afford to use a new cover for each patient. I'm scanning more than 15 patients in a shift. So what I do is to clean it like any other materials, instruments in the room of the patient, like the stethoscope, the other instruments like the sphygmomanometer, the thermometer, everything else. We use the Vircon to clean it. And what about inside the cover? You can use the same you use without COVID-19. In our case, there's a list provided by the ultrasound companies, and also from any hospital has its own protocols to clean these devices. In my case, we use chlorhexidine, a non-alcoholic, or the sulfasafe, which is commonly used for the portable X-ray machines and other chirurgical instruments. Be careful with the gel, especially with the bottle gel, as it can get contaminated, and it is a source of infection. So what I do is to use these single-use packages of sterile ultrasound gel, or this another idea which I saw a couple of days ago on Twitter, that was a really good idea, to use single syringes full with the gel, and I use 1 or 2 syringes for each patient, and then with the remaining I just by the end of the exam I throw it away. This is the protocols I asked permission to Chuck Russell from Canada to let me borrow to use in this presentation. I wanted to bring it out because I found it really useful. And the main tips to use this protocol is that you need to follow the main rule of coming inside the room clean. You need to clean the device before entering, and clean it twice after finishing the scan exam. Besides that, anytime at any step you need to clean your gloves, sanitize, use the cleaning solution, and therefore each step you are doing at taking off your personal protective equipment, or taking off the cover, you need to be sure that your hands, your gloves are clean, and by that you need to use the Vircon at each step. And one of the tips I found it most useful is to prepare a basin with all the things you need to perform the exam before entering the room. So let me show you. This is my basin with the probe in the center, the gel syringe, some wipes, the cover that I put it on the ultrasound right before entering the room, some extra covers if I need to do any procedure, and the chlorhexidine. So I have 3 basins, one with all the stuff I'm gonna use, the second one to disinfect after the exam. It's full of Vircon. I spray the whole set, the whole device with the cover on it with the Vircon, and then leave it there and then let it dry. And the third basin is in the clean area where I put the ultrasound after the exam. It's harder than what you might think. It's still much easier than using a card-based device. So my recommendation is anytime you start to do the ultrasound, first take a morning to get familiar to the procedure, to do a quick learning curve on how to implement these steps into your practice, as sometimes can be harder to do it. As you can see in my picture, when I dropped the ultrasound cord, it fell on the contaminated floor. So afterwards I need to with my contaminated gloves, I need to clean the whole set and then re-clean it again. And this is the protocol for card-based machines, which follow the same principles. The difference is here, that you need before entering the room to remove anything you are not going to use, extra cords, probes, and removing any stuff you're not gonna use. And then the same, clean it before entering, clean it twice after the exam, and sanitize and clean your gloves at changing any step and moving forward. Some of the rules I will suggest you to follow to make it the exam more successful or easier is first of all, you need to perform the ultrasound only if by doing it you are gonna change your management. Some of the indications are when you have a false negative test or an X-ray, as the sensitivity for the PCR test is around 70%, and for X-ray to find interstitial disease is around 60%. So now we have another tool that could allows us to do to overcome these limitations. Also, in borderline patients who are not that sick, and you might think of discharging them, or you might think that if there's many pathology in the many findings, pathological findings in the ultrasound, you might think of admitting them. Any change in status, as all patients have comorbid disease such as heart failure, COPD, you can use ultrasound to monitor and to rule out any other. And also don't forget that they have a great risk for pulmonary embolism as well, or severe bacterial infection. So ultrasound is a powerful tool to help us to rule in this disease. Also, to guide any procedure, many of these patients are very sick and need to be admitted to the ICU, so you use ultrasound to guide the insertion of a central venous catheter for the orotracheal intubation, for any other procedure that we usually will do an ultrasound guided. And as I mentioned before, to early discharge a patient with good saturation, if you or your hospital protocol, like in my hospital, to discharge these patients, you need to do an X-ray. Why wasting the time? I'm exposing that patient in a room with many other patients, and they're waiting for an X-ray that can take around 2 hours to be done. Why not doing a quick ultrasound, and then you can early discharge them? As I mentioned, this we can argue why we're doing X-rays to these patients at the beginning, but well, that's another discussion. Here we have a patient with mild symptoms who got tested for COVID, and the test result was negative, but the ultrasound, as you can see on the lower lobes, there was a confluent B lines and some subpleural consolidations. So this patient was highly suspicious of having COVID with a false negative PCR, and then because her symptoms were worsened 4 days later, she got another PCR and turned to be positive. Let's talk about the personal protective equipment. Some centers, they suggest that this should be enough to assess a pre-triage COVID patient with the green gown and the gloves. Well, I slightly disagree. First of all, you need long gloves to cover the whole wrist to your arm, and then you should wear something more impermeable with more protection, as this personal protective equipment is the standard of care in these patients are running out, and we're running low on these results. This will be in the ideal situation. We have to move to an intermediate situation where we use long gloves with a screen shield, mask, and the white glove that we use for each patient. And then if we need to see many patients at a time, we need to try to not touching any patient with my gown, and then change my gloves every time I see a different patient. Third, we need to use an abbreviated protocol. We are not learning, we are not performing fancy measures. We need to, instead of auscultate my patient, I do a quick ultrasound to see, to find main findings, concerns about what is happening to my patient. So I do a quick protocol that doesn't take me more than a couple of minutes. And so I start with the posterior lobes of the lungs, and then in the focus echocardiography I start in the subxiphoid window. Most of the exams I perform, I do it with eyeballing. So I eyeball the IVC, the heart, and the lungs, pretty much. And don't forget that, as I mentioned before, take a time to do your learning curve, as these patients, it's slightly different than what we have seen before. Many of these patients are really sick, and it's hard to move them upside down and to look at the posterior lobes, and sometimes you need to see what the patient allows you from its current situation, allows you to scan. Here you have my Twitter account and my email. Feel free to email me with any questions, with any concerns. Thank you for your attention.
I'm going to talk a little bit about cardiac involvement in COVID-19, but since we don't know very much about it, I'm going to make my presentation and suggest some things that we should seek in these patients. And by the end of the presentation, I'll show a case that we have right now in our ICU. Okay, so I'm going to share my screen right now. And I'd also like to thank all my team, and especially to Tiago Giraldi, who is our frontman in the ICU. He's a doctor, he's an intensive care doctor, and the images from the patient, all of them were performed by himself. So now I'm starting to share my screen. I'm going to talk a bit about the challenges of COVID-19 management in our ICU. I have a disclosure to make. We have a partnership with GE Healthcare. We use some of their ultrasound machines here, and we are currently making two research projects with the partnership of GE. So To start with, I'd like to suggest some moments to perform cardiac ultrasound, but not only cardiac ultrasound, but also lung and point-of-care ultrasound in COVID-19 patients. So, patient's admission to seek for alterations in lung and heart and IVC mostly, but also other organs. If the patient becomes unstable during his stay in the ICU or in the ward or anywhere else, and also in patient's discharge. Of course, we should perform point-of-care ultrasound also to screen patients in the ER. I'm here talking about the admission, stability, and discharge from the ICU, all right? And what should we seek for in these examinations? We should assess the preload status mostly by checking how the IVC status is. We should assess the contractility status by the eyeballing technique, which is we see the heart from different windows and try to figure out how the contractility is. We should eyeball the chamber size, and if you are trained in more advanced echocardiography, you should also assess relaxation, and we always do this by because we are supported by our echocardiographic team here in our hospital. We can also measure LV filling pressures. I'll show you later on the presentation. We can also assess afterload, and we can also measure cardiac output. So, as you can see here, we have three different images of the ICU. In the middle of the screen, we have a normal ICU, which is, it didn't work. Let's see if we wait for a while and it works. But in the middle of the screen, we have a normal a normal IVC, and on top left of the screen, we have here a plethoric IVC, which might mean that this patient have many conditions, not only he's hypervolemic, but he might also have an RV problem, like an RV infarction of pulmonary hypertension. And in the bottom right of the screen, we have a very collapsed IVC. So we always perform the IVC examination in order to see how preload is. Now we have this plethoric IVC. Here we have the normal IVC. And here we have the collapsed IVC, okay? So moving up to the next slide here, we should seek for contractility status and chamber size. Here is a normal heart, okay? So we can see that the right ventricle is small, and it's about 60 or 50% of the size of the left ventricle. And here we can see an enlarged right ventricle, which has not been very common in these patients. We were expecting to see larger RVs in these patients, but I talked today with my consultant, my echocardiographic consultant here in my hospital, and he said that he and his colleagues haven't seen many enlarged RVs in COVID-19 patients so far. And here in the bottom right of the picture, we can see an impaired left ventricle. You can see that the contractility of the left ventricle is not very good, but at the same time, you can see that the right ventricle is very small. So this patient might be hypovolemic, because a way that we can see the volemic status is also to see a small right ventricle like this. All right, so it's very easy to see, but we have a normal heart to compare, like this one in the middle of the screen. Okay, so what do we know right now about the heart status in COVID-19 patients. First of all, we have reported cases of myocarditis, but this is mostly MRI studies. We have not enough echocardiographic studies to see if this have been seen with echocardiography. So this is a field for research. We also are asking ourselves if RV involvement of or pulmonary hypertension is common, but so far we don't know. So this is something that we should seek for. And I've seen yesterday a case report of a patient that had myocarditis with complicated with pericardial effusion. So it would be important also to seek for pericardial effusion in these patients, because this can complicate the distributive shock that these patients usually have. And we should also know that the most common cause of shock in this patient is distributive shock, complicated or not by myocardial depression. Okay? So I'll jump to the case presentation and then I will finish my talk, right? So this is the case I'm going to talk about is a male, 17 years old. He has hypertension and he has obesity as well. And he had low fever and cough 8 days prior to admission. In his case, his clinical picture was worsened by dyspnea 2 days before admission. So I'm not going to go very far in the long ultrasound because this has been well spoken by Maris and Blaiva so far. So I'm just like to show some findings. So we have this irregular pleura here and maybe a micro consolidation here and a irregular pleura here too. And this other image is interesting because, as Marie said, we can find a normal lung A pattern along with altered lung. So it's very important to go through a thorough examination of the lung. And this is a detail of the thickened pleura with maybe a hypoechoic image here, which might represent a small consolidation as well, just like Blaiva said minutes ago. And this is a pattern of thickened B lines all mixed together, showing a kind of a white lung. And this is the IVC and the heart of this patient. So as we can see, the IVC is mildly plethoric. We can see the hepatic vein here. So we saw that this patient wasn't probably hypovolemic. He was intubated, but his PEEP wasn't very high. So we had the impression that this patient wouldn't benefit from volume at this moment. As you can see here in his heart in the 4-chamber view, we can see that his right ventricle is kind of small and he has preserved LV contractility. But as we went further in our cardiac examination, we saw that his relaxation seen here in the pulsed wave Doppler in mitral valve during diastole, we saw that the E wave was kind of a little bit taller than the A wave. But as we know, we shouldn't assess diastole only with pulsed wave Doppler. So we performed the tissue Doppler imaging of the mitral annulus. And what we saw here is an alteration of the E prime to A prime ratio. Here I measured the E prime and also the E to E prime ratio. So his E prime was normal, was 9 centimeters, was in the low range of the normality, and his E to E prime ratio was kind of low, meaning that this patient had normal or near to normal filling pressures LV filling pressures. So keep in mind that we had normal preload, we had a wet lung or altered lung with a lot of B lines, but we had normal filling pressures with altered relaxation. And here I show you the S wave, which correlates with afterload. Okay, so his S wave was in the upper limit of normality. It's 14. So as it correlates with afterload, his afterload was normal or near to normal. But he was on, at this point, he was with norepinephrine. So probably his vascular resistance was low, and we kind of increased it with norepinephrine. But the presence of the S wave within the normal range might mean that his afterload was okay. And also his cardiac output was preserved, was actually in the upper limit of normality. Actually, his cardiac index was in the normal, was in the upper limit of the normality. His VTI was kind of high, so he had a good contractility. And when we saw, so here we have the E2E prime, we have the cardiac, the frequency, the heart rate was kind of low at the moment of the exam. He wasn't very tachycardic at no moments in the exam, and his cardiac output was high, was up to almost 8. But he's a tall man, so his cardiac index was 3.5, and his S wave was 14. So he had a good preload, he had a wet lung, but with normal LV filling pressures and impaired relaxation. So our impression was that he had a distributive shock, not in distributive shock, not complicated by a cardiac involvement because of the reasons I mentioned before. So to conclude, the patient was similarly okay with the preload. His contractility was okay by eyeballing. He had impaired relaxation, the E prime to E prime ratio. His LV lung filling pressures were okay. The E2 prime was okay, but we must be careful because patients who have altered contractility in large left ventricles, we cannot trust this E2 prime ratio. His afterload seemed to be low and vascular resistance low because of the tall S wave, and the cardiac index was in the upper limit of normality. So as I said, it seems to be a distributive shock, not complicated by a cardiac involvement. So I don't have a take-home message because we all should stay at home. So I have some stay-at-home messages. First of all, follow your institution's protocol, clean your machine very well, and respect this disease because it's very severe. Use cardiac ultrasound wisely because we actually don't know its usefulness so far. So we should trust our clinical judgment to take the best decisions for the patient, all right? So thanks again, and see you soon after this pandemic finishes. So thank you.
Nice. Hi, Mike. Hi, Tiago. Hi,
Hello.
Costa, and hi, Yale. Yeah, after all these technical problems, I think it's easier to treat COVID-19 patients than to put the webinar on. In the last 2 hours, I was more stressed than in the COVID unit. Okay. Thanks a lot for your commitment with this. I know that this is it was very difficult. Mike worked yesterday till late, and Costa Also, Tiago, I know that is running on the ICU and Yale. I don't know, Yale. You came recently from quarantine, yes, or
Yes, yes. This
yes?
week is my first week.
Okay, Yale. I will start with you. How the things are going in Madrid, because you are like listening every day newspapers and so on, and the things are getting worse, or do you think that you are now reaching the plateau?
We are already reached the plateau this week. This is our third week of quarantine. So we've seen that many of the cases has stabilized the curve. And so in the plateau, as we are now, we can see less patients and better assess them. So now is the time when we need to put more ultrasound and to better see those patients, because the problem that we had is that we applied so much the protocol that we forgot to assess, to see
Okay.
the comorbidity and to treat those.
Yeah, I will stress that, because the ultrasound, it's not only needed in the COVID-19 patients, but not for only for the lung or the heart. My last shift, I had a problem with a neurological patient that was COVID positive and need a cystostomy, and I had to give like assistance in the physical exam. All the doctors were afraid of touching the patient, and then with the ultrasound was easy, okay? And the urologist, all paramented. It was strange to see a surgeon with all the things like treating a COVID patient, but with the ultrasound helping other problems that not directly the lung ultrasound. I don't know if you agree with me.
Yes, totally. We had a patient with appendicitis, and the anesthetist wouldn't want to put general anesthesia to this patient before the CT scan of his lungs, and the surgeons didn't want to go
Yeah,
before you you know.
I know it. Yeah, Mike, and what do you think? How much time you need? Or I talk this because some of the people are watching us. They have some experience with lung ultrasound, but they are asking us like for the subtleties, and they want to see again the videos and so on. How do you think that you need time to learn the COVID alterations in a lung ultrasound? Is it like really difficult, or it's relatively simple?
I think it's simple as long as you know some ultrasound basics, have good examples, and a good explanation of some of these details. Because if you've grown up with lung ultrasound, you heard only of B lines, A lines, some other descriptions of consolidations, but there was not much differentiation between different types of reverberation artifacts and their relationship to the pleura, because some of the earliest work couldn't image the pleura very well. I think with the right examples, it'll be easy to learn. It's just you have to make somebody understand it's not looking at one spot, let's say like at the gallbladder, but putting it all together from both lungs, front, sides, and back. So it's a little bit of a challenge. I think it would be harder than learning how to do a DVT scan, at least for me, but not as difficult and challenging as cardiac or, let's say, gallbladder, since I use that example.
Yeah, for all the folks that are still watching us and they had patients, we will edit all the images and all the presentations, and you could see and the presentations and with the videos running on, and we'll try to put the things like poster that show the great videos, and Mike and Yale and Tiago, and also the cases I presented, and to be properly seen at home, and to be more pedagogical. Okay, thanks, Mike. And Tiago, what are your like main difficulties to put the ultrasound in Brazil, and or in other ways? I think Brazil is like with a bit of a lag between the other countries. Now it's reaching like the point of crisis. Okay, And what are your main difficulties in your hospital?
Well, we are starting to have difficulty in PPEs, even prior to the pandemics itself, and this extends to the machines, because we need to protect the machines, we need to protect the probes, so we need to use, as Yellow showed us, we need to use small amounts of gel. So we need to be prepared, not only ourselves, of course. First of all, the security of the team must be assured, but also not to contaminate the machines and not to contaminate other patients with the machines. And this is especially true because in some parts of our country, the tests are not readily available. We are starting to have the tests in our university right now, and we are performing the tests in the university, because here in our state, the tests are concentrated in just one spot. So we need to be very careful with the machines and the personnel. And this is why I think the PPEs are the most important challenge right now.
Yeah, I think this is a problem in every country with shortage of things and so on. Fortunately, in Portugal, we are like flattening the curve, and yeah, we have the problem in some hospitals, mainly in the smaller hospitals. But hopefully, we are having the cases not only at once, and we can manage that. For me, it was really a good idea. I've discussed it yet with Tiago by WhatsApp and so on. The idea of putting in syringes the gel, and it's really I already asked it to the pharmacy in my hospital, and they will dispose. It's relatively easily to ask them and to make like 50 syringe each day and to put in the emergency department. I think really it's a good idea that is affordable, it's cheap, and every hospital could easily make it. Then Costa, thanks a lot, because Italy is for us in Europe, unfortunately, the example, and then all the countries that saw the tragedy. And I will ask two things. Do you think now the last slide, you put a slide of hope? I think you are now controlling the situation. And then what do you think it's needed to put, like the algorithm you told? You put in the other slide. We are not hearing you, or I'm not hearing you. Yale, he has to leave. He is in the hospital working. Thanks a lot, Yale. Thanks a lot, Yale. Costa, we didn't hear you. Now, are you hearing?
Perhaps the microphone is off.
Yeah, Costa, we listened to you so well in the presentation.
Yeah.
Now I think the COVID is like infecting our internet.
What is now? You can hear me?
Yeah, clearly.
You can hear now? You can hear now?
Yeah, I'm
Okay.
hearing you.
So,
yeah.
Okay. I try to answer to your question. Your two questions. I hope that we are on the plateau. Maybe it's difficult to say, but I think that we have to continue to do this battle. Don't think that we have win, because the situation is still very hard. Each day we see a lot of positive patients, so for now it's a hope. We have to try to do the best, to continue to do the best, and until we see zero, in my opinion, because this is the right thing to do. And on the second questions, I think that the algorithm may be very useful. We have to do something to study this situation.
We have to do trials, to do studies or large cohorts. And I think that about 3 weeks ago, I spoke with Mike and I said the correct thing that I didn't think to be, but he said to me, this work, this suggestion, this algorithm will be very useful because if the virus come again next year, he said these words I still thought is right. We are thinking now to do the best. We are thinking to do ultrasound. All is correct. All is correct. New therapies, but we have also to think to the future because, like influenza, we can risk that the virus come back again, and so we have to be prepared. This is fundamental because we are paying in all the world a lot of death. So we have to prevent this situation. I'm sure we will win because medicine always had win in the history. Always, always. Also where we haven't antibiotics, but the price is very, very, very high. The price is very high. Also now. So I think that the trials we have to when we all finish. We have to think the trials, the studies, the strategies, and we have to adopt the best strategies. Looking at all the world, who says the best strategies will be the future.
Thanks, Costa.
this.
Costa. I think it's a great message
Thank
because
you.
one of the things that we may relax in some countries to see that okay, we'll reach the herd immunity and then this problem will go away and with a vaccine and so on. But we have to see that probably these problems will come again, and we don't know when they will, and we have to be prepared. And these pandemics, it's like even an humility to our health systems, and I think it's a great opportunity to change our health systems, even the emergency departments. Paradoxically, I'm liking to work in some aspects in the emergency department. Try to see my words in the right context, okay? Because we have like seen the more controlled situations because we are looking ahead and we are preparing ourselves for the worst. And I think we have to put that reasoning in all the things in the health system, not only for COVID, but to tuberculosis, to malaria, to the other problems of the emergency department, the overcrowding. And ultrasound in a humble way, I think it's because it is transversal to all colleagues. And I think it's an opportunity to change and to change for the better. I don't know if if you understood my words.
Sure.
Do you have any message? And again, I apologize for all the delays. We are all doctors in the front line. Yale has had to leave to treat a sick patient, and we are all like with a lot of work on our backs, and even then trying to put the things running in home. My daughters are like with 5 and 9 years old, and to give attention to the family and so on. I have to thank especially again to my wife because he helped me to put all these things and up front, and to Josh from stage 10. He was amazing. And for you, my friends, I deep from the heart, and thanks a lot. We'll try to put these things clearly on and in a continuum, because a lot of our friends and so on that register, they are asking to see the presentations. And finally, I only ask to you if you want to leave any message to our colleagues.
So I also would like to thank everyone. Thank you, Maris, once again. I can't wait to fly back to Portugal and be here with you guys. Miss you all. Thanks, Mike, for the nice presentation. Thanks, Constantino. I hope we are going to work soon in a huge lung ultrasound protocol. I think we have much to learn from one another and many things to work together with. And we hope that we will overcome this pandemic soon. And thank you very much.
I do think this is a real time where lung ultrasound can shine and show its true potential for bedside diagnosis, monitoring, care, making decisions, and therapeutic interventions like never before. So despite the tragedy of this pandemic, we may be able to move lung ultrasound forward quite a bit, and we should, because of the efficiency it presents care-wise and cost-wise to society. And obviously, if it can replace chest CTs to some degree in parts of the world for cases like this, decrease radiation exposure and deaths that follow from that.
Then Costa, have you anything to? Yeah. Thanks again to all of you, my friends, and I think this will be the first of other webinars. Okay, we will try to put the internet less infected. Okay, and take care. And to all the people that had patience to be at the end with us, hope that this will be inspiring, and we are open by this channel in YouTube, or then by our page or in the Portuguese Society of Internal Medicine. We can contact us, and if you have any doubts, and we'll share with you our protocols and so on. Okay, take care, and let's finish this adventure. Okay.